Yeah. Good evening, everyone. I say evening because it's evening in Stockholm, at least. I just wanted to wish you welcome to the third webinar of EUPSA Global Pediatric Surgery Committee. And today we have the honor to have with us Professor Emmanuel Ameh from Abuja, Nigeria. But Eva will introduce him a little bit further, who knows him personally. And moderating this session is me and also Gonca Tekant from Turkey and Eva Stortelder. Gonca, do you want to add something to the
Yes,
welcome?
actually, thank you, Anna. We just want to tell that this will be recorded, this webinar, and it will be on the EUPSA website in a couple of weeks after editing. And if any of our members or would like to watch the previous webinars, they're also available on the EUPSA website. Today, Eva Stortelder, who is a young pediatric surgeon in our group, who is actually practicing in Utrecht and Brussels, will be giving the introduction for Professor Ameh. And actually, Eva has a quite, well global pediatric surgery history in her training. She was in Malawi for United Nations in the past. So she does have an insight to what global pediatric surgery is. And we are very happy that Eva has invited Professor Ameh to this webinar. So please, Eva, go ahead and just continue with the introduction. Thank you.
Thank you so much, Gonca, and welcome, Professor Ameh from Nigeria. We are very honored and proud to have you here with us for this webinar. Professor Ameh is a professor and chief consultant pediatric surgeon in the National Hospital in Abuja in Nigeria, and he's also the current president of the Pan-African Pediatric Surgery Association. But his involvement in global surgery goes way back because he was involved in the Lancet Commission for Global Surgery, and he also worked on the implementation of the National Surgical Plan for Nigeria, which was the first ever country surgical plan to include and prioritize children's surgery and perioperative nursing. He has been a long-time advocate for scaling up access to safe and quality children's surgical care in Africa and low and middle-income countries. And he continues to invest much in training the next generations of global surgery practitioners and pediatric surgeons. So thank you so much for being with us, Professor Ameh. We look forward to your talk about surgical care as a catalyst for disability prevention and sustainable development. The floor is yours.
Thank you so much, Eva, for those kind words and greetings to everyone from Nigeria. My aim is to share some of my thoughts about what direction I think we should begin to move global children's surgery within global child health. And what I'm going to try to do in the next few minutes is to illustrate a little bit how timely surgical care can transform lives, and then how we can reframe children's surgery as an essential first-order intervention in preventing lifelong disability, and end by making a case for children's surgical care as a developmental investment rather than a costly intervention. And I'll start by maybe a little bit of data or information that we all probably already know. In 2017, some of the work we did at the Global Initiative for Children's Surgery indicated that 1.7 billion children and adolescents at that time did not have access to safe, timely, and affordable surgical care. But as you can see from the chart, majority of that population of children are in low and middle income countries. Actually, if you take only low income countries alone, nearly 98% of children in those countries really have no access to safe and timely surgical care. And many years ago, some of the work that some of our colleagues have done in Africa showed that cumulatively, by the age of 15 in sub-Saharan Africa, about 85% of children will develop a condition that will require surgical care. And I think this information is really so important because it gives some idea about the magnitude of the burden of surgical problems that we have in low and middle income countries, and also the magnitude of unmet needs that presently exists. Because of this burden, some of the things that has happened in the last decade, and I say last decade because I think that after the report of the Lancet Commission on Global Surgery and the WHO resolution 6815 of 2015, so much has happened. There has really been a very rapid progress in global children's surgery. Much of that progress also revolves around the role that the Global Initiative for Children's Surgery has played. I think that one of the things that all of us together have done in the last decade is that we've really generated so much data beyond what was existing previously. We've come up with different types of metrics to measure the cost effectiveness of children's surgery and evaluate the unmet needs that exist. Because of that work that has been done, there's now an increased visibility and awareness and advocacy for children's surgery globally. We've been able to gradually get children's surgery into policy and planning by way of including them in national surgical plans, especially in sub-Saharan Africa. We've also become better, both from the global south and global north. We've become better at sharing knowledge, at education, and at collaboration. We've also been able to make some progress with infrastructure for children's surgery. And I think a good example is what the Kids Operating Room has been doing across low and middle income countries by creating children's operating room. These are all very impressive and inspiring progress that have happened in the last decade. However, despite this glowing progress that we have made, we continue to face challenges with global children's surgery. And I think that the biggest elephant in the room in that challenge is financing and funding for children's surgery. If you look at how much money goes into child health globally every year, billions of dollars go into vaccines and immunization, infectious diseases, tuberculosis, malaria. But if you take the entire surgery, and when I say entire surgery, I mean both adult and children's surgery, less than 1% of the total global health funding goes into surgical care. So, and really, that doesn't amount to much. And the reality is that no matter how much progress we are making, without funding, we are significantly limited. At the Global Initiative for Children's Surgery, a few years ago, we looked at the impact of catastrophic healthcare expenditure for surgical care in children in sub-Saharan Africa. And one of the things we found was that 40% of families in this setting incur catastrophic healthcare expenditure due to out-of-pocket payments for surgical care. That is huge. We actually know that 40% is an underestimation because the focus of this work was on tertiary care, and we know that the majority of the population will access care at district hospital level, which doesn't include tertiary care. So if you include district hospital level, this percentage is going to be huge. So that's a big problem we face with financing for children's surgery. In addition to problems with financing, despite the increased awareness and visibility that we have achieved in the last decade, we continue to face problems with actually getting children's surgery into the global public child health agenda. Our public health colleagues really don't seem to understand much of what we are doing in children's surgery. And I think that one of the problems we continue to have is that we have continued to talk to each other and within ourselves. For instance, this webinar we are having would have been very helpful if we have our public health colleagues joining the webinar. Then they will begin to understand us. But somehow, we've not been able to break significantly into that public health space. We continue to have very serious workforce gaps, especially in the global South. So the question is, despite the progress we have made, why do these challenges persist? Shouldn't we begin to reevaluate our approach and maybe begin to modify our approach? And that will be the focus of what I want to share with all of us this evening. Talking about mortality, the global child health has really been very successful over the last several decades in reducing under 5 mortality from medical conditions. And a lot of the current high under 5 mortality in countries like Nigeria and India are driven disproportionately by surgical conditions. One of the problems with focusing on mortality is that it tends to flatten outcomes. And why is this so? Because if a child survives with an impairment, that is still counted as survival if we are focusing on only mortality. And I'll give an example. If you take a child with esophageal atresia, for instance, a lot of our focus is the fact that the child survived. The child did not die. But and that's what we count in most of our research work. There are only a few researches that go into the long-term quality of life. What happens to that child in terms of their swallowing and eating abilities as they grow older? Do we even know what psychological impact that condition places on the child? We are not assessing that. So that's a problem with focusing on mortality. And the problem with health systems is that once mortality is counted, health system completely forget about what other subsequent impact the condition is making on the child. And many surgical conditions in children, as we know, those conditions that are not life-threatening, they produce disability very slowly. So many of those children are left. Yes, we have counted them as they are alive, they have survived, but they're actually not living very good quality of life. They may not be integrating into the society properly. They may actually not be very economically productive, and their issues may persist for a lifetime. So that's one of the limitations with mortality. So should we begin to go beyond mortality when we try to promote and advocate for surgical care for children? We also know that children, they actually develop. They don't just survive, which is important. So, and I think that if we focus too much on mortality and we are counting survival without looking at what happens to development and function, we are then ignoring how growth is proceeding. We are ignoring their learning and cognitive abilities. We are ignoring their social participation, because we do know that many surgical conditions leave the children socially isolated, and that creates some long-term impact. We are also ignoring their economic independence. So this is a huge problem with mortality. But I will leave mortality aside for a moment. The disability adjusted life years were created as an improvement over mortality, to address some of the disability that can happen. And this was a very important and very useful metric. And if we look at the dailies that can be averted or that are associated with different conditions, we can see that surgical conditions alone, if we are able to provide adequate care, they can significantly avert much more dailies than tuberculosis, malaria, HIV, AIDS, which really get so much funding. But despite this knowledge and this metric that is available, we are still not able to attract significant financing and funding into surgical care. So what's our problem? What's the problem with dailies? And I think one of the problems with dailies is that in terms of children's surgery, I think that it underestimates the impact of surgical care for children. And why is this so? Because it doesn't capture the lost developmental potential of the child. It doesn't capture the educational exclusion of the child. It doesn't capture what happens to the caregiver, the burden they face, the family, the challenges they face because a child in the family has a surgical condition. And it also doesn't capture intergenerational poverty due to loss of workforce participation. And more importantly, there is significant misunderstanding or lack of understanding of dailies within policymakers. And we need those policymakers to understand what we are talking about. What that means is that ultimately, many times the dailies ends up becoming academic and becoming more of a research tool for those that already understand what it's all about. So should we begin to look at something else that will help us put mortality and dailies together in addition to what that something else is, to help us to begin to generate the kind of redirection of financing that we are looking for? So, but going back to disability, and this is where mortality is so limiting. Disability is a hidden outcome. Up to 75% or more of the impact of surgical conditions in children are related to different types of disability. And when I talk about disability, it includes both physical and non-physical disabilities. So again, I'll go back to survival. The fact that a child has survived does not mean that we have been successful in completely addressing the child's problem, because we haven't looked at function, we haven't looked at social inclusion, and we haven't looked at productivity. And these are some of the aspects that we need to begin to capture more attention for children's surgery. Most surgical conditions, ranging from congenital anomalies to tumors, have the tendency to produce some amount of disability if they are not treated at all, or if there's delayed treatment, or there's no follow-up treatment that is required. So we can't ignore disability completely. And we do know that some of those factors that are responsible for delays in assessing care for some of these surgical conditions are multifactorial, ranging from delay in seeking care, delay in reaching care, and even in delay in returning for ongoing care. But the common denominator for all these delays is money, right from the delay in seeking care to delay in returning for ongoing care is lack of money. It's responsible for most of them, and that is why financing is so important. But these delays are intricately linked to the entire healthcare system in a way that cannot be ignored. And I'll come back to this later. But I think the bottom line is that when those delays occur, they are the consequence of system failure. rather than the responsibility of the families or whatever is causing the delay. So in the light of this, should we begin to reframe children's surgery advocacy in a way that makes it possible for us to generate the kind of attention that we want beyond what we have achieved presently? Because I think that 10 years is long enough to generate the kind of attention we want, but we don't seem to be getting there. So for me, I think that my opinion is that surgery goes beyond just providing cure. Surgery prevents disability, and surgical care really spans across almost an entire lifespan. And if we take children, surgical care spans from neonatal period to adolescence. If you take most serious congenital anomalies, their treatment doesn't end just in the neonatal period. Many of them require some form of ongoing care, even up to adolescence. But this tends to be, even on the medical aspect, this tends to be underrated. There has been a lot of focus on the first 1,000 years, 1,000 days, the under 5 group. And the age group after that up to adolescence seems to have been forgotten. And then we jump to adult care. So one of the things we have done at the Global Initiative for Children's Surgery recently is to focus on the first 8,000 days as a whole, which is a spectrum from neonatal period to adolescence. And we've tried to use that to raise awareness on the reality that surgical care is not just a one-point kind of thing. Surgical care covers the entire spectrum up to adolescence. And this becomes even more important if you look at the current median age for different continents. See where Africa is. The median age in Africa is 18 years. So these are all children up to adolescence. And from what I said earlier on, that 85% of children in sub-Saharan Africa will develop a surgical condition by the age of 15 years. This means that a huge population of children and adolescents in Africa require surgical care to prevent some form of disability. I think that this is such a compelling information that we can use for advocacy, that policymakers can easily understand beyond mortality and dailies. And the point is, I think the bottom line is that if we can provide timely surgical care, we can do at least 4 things. We can restore anatomy and function. We can prevent deterioration in function. We can also prevent developmental delays, and we can prevent chronic disability. And I think this is an aspect that policymakers can easily understand beyond going into the complexities of dailies and the limitations of mortality. So if I think that we need to begin to reposition surgery as both for primary prevention of disability and for secondary prevention of disability. And I think that the message or our messaging should begin to change to the fact that if we can provide timely surgery, we can improve functional outcomes, we can improve education for these children, but the end point is economic productivity. If there's no disability, then that child, when they reach adulthood, they are likely to be economically productive. And I want to maybe go back again to those surgical conditions that don't cause an early mortality. They tend to be completely forgotten. Unfortunately, this same type of surgical conditions produce a lot of functional disability and a lot of social isolation. And also many of them may not be economically productive. And they end up being faced with lifelong disabilities. And if they are either not treated early or poorly treated, and examples are bladder extrophy, clubfoot, even cleft lip and palate, and those with anorectal malformation and Hirschsprung's disease. And in sub-Saharan Africa, for instance, we have huge numbers of these kind of conditions that have either been untreated or been poorly treated, or their treatment has been delayed, and they are all ending up with significant disability and becoming a big burden on society. Neural tube defects are another big component that are not getting properly treated. So, and this is where, if we are focusing on mortality, these conditions easily get forgotten. And I think that surgical care is not just about health and well-being. Unfortunately, we keep focusing mostly on health and well-being. And we do know that most policymakers are familiar with the Sustainable Development Goals. I think we need to begin to get them to realize that surgical care impacts on several SDGs, from preventing poverty, from making sure that the children are able to go to school, they are not missing school days and school time, they are able to learn properly, they can integrate into society, and eventually they will be economically productive and will be able to cut down on inequalities. So if we are able to reframe surgical care properly as preventing lifelong disability and also preventing intergenerational poverty, that really will begin to capture the attention of policymakers and funders in a way that our public health colleagues have been able to do over the years. And public health people will also begin to understand us. So if we fit surgical care into the SDGs, what we'll be able to show is that children's surgery is a development investment rather than a costly intervention. Because unfortunately, despite all our advocacy, policymakers continue to see children's surgery as a costly investment. But I think what we need to let them know, convince them, is that it's a developmental investment. And we need to properly capture for them what having early surgical intervention means and what it's able to achieve, and what having surgery delayed, what it means. So what do I then think that we need to begin to change in order to reframe children's surgery within global child health? I think the first thing is to emphasize that surgery is not only curative. Surgery is also preventive and restorative when we talk about disability. We also need to begin to change our emphasis in terms of the metrics that we are focusing on, so that we are not focusing on only mortality and dailies. We should be talking about disability-free survival. And we shouldn't be talking only about including children's surgery in surgical plans and universal health coverage packages. We've tried to do that in the last decade. That has not got us to where we want. I think that we now need to begin to make sure that children's surgery is captured in SDG packages. We need to begin to humanize the data that we have. I think one of the problems that we have as surgeons is that we tend to focus too much on data and statistics. But we do know that data and statistics alone don't move hearts and don't move pockets. We want to get into the pockets of funders. They are not, if we are saying that 1.7 billion children lack access, that is a very strong information. But I think the downside of it is that it tends to give the impression that this is an unsolvable problem. Because if you tell a policymaker that 1.7 billion, I mean, where are you going to start from? How are you going to begin to solve that problem? So I think that we need to break down the data that we have in a way that policymakers can easily understand. If we are saying 7 out of 10 children lack access, that is easier to process than the figure of 1.7 billion. And I think that we should not over generalize the data that we have. We should contextualize whatever data we have for policymakers in different settings. I think that one of the things we've done in the last decade is that we've generalized too much data, and it's becoming difficult for policymakers within countries to really understand what we are talking about. We also, in terms of humanizing the data, we also need to begin to emphasize the life course of surgical conditions. And I give an example of cleft lip and palate. We should be able to say, bring it out clearly. If the condition is not treated, this is what is likely to happen from childhood to adulthood. If the condition is treated, this is what is likely to happen. Again, policymakers can easily understand this rather than the very large data that we have. And an aspect that we have ignored is telling the real life stories of children and their families with surgical conditions. Again, the obstetrics group and the public health group, they've been able to do this very well. Because again, it is the stories, individual stories, that touch hearts and pockets, not the big figures. So we should be able to come up with stories of children who are living with correctable conditions, who die from correctable conditions, and who become disabled from untreated or poorly treated conditions. This would then begin to highlight the unnecessary suffering that those children and their families are going through. So, and if we combine this with the data that we have, we are more likely to capture the kind of attention that we are looking for. Another aspect is that I think we need to begin to move away from charity narratives. I think for too long, we inadvertently have portrayed children's surgery as a matter of charity and focusing on external aid. I think that this has the risk of perpetuating a cycle of dependence on external aid in low and middle income countries. And that also tends to make governments not to invest, because once anything is seen as a charity initiative, government will wait for charity. They won't put in their own money. So I think that, and if we portray them as charity initiatives, that can also potentially obscure the systemic gaps that drive poor access. And I've mentioned the linkage between the systemic gaps and the delays in access to care. These systemic gaps are so crucial. There's no way charity can address these systemic gaps in a sustainable way. We need governments to invest in them. So we need to gradually move away. Charity is good, it's helpful, but I think that shouldn't be our emphasis. Our emphasis should be on creating sustainable and resilient and equitable surgical systems within countries so that they can survive on their own. So I think at the end of the day, my point is that we should reframe and reimagine our narratives about children's surgery as an investment in disability prevention and economic productivity, rather than as a curative initiative. So I'll stop here for now. Thank you so much for listening.
Wow, this was a wonderful lecture. Thank you so much, Professor Ameh. We can now go to the chat to see if there are any questions. Otherwise, I would have a question. I don't know, Anna?
No questions so far, but I put a note there telling anyone you can use the chat function or raise up your hand, and we will pick it up there if you have any question to Professor Ameh. Do you want to start, Eva?
There is
Yeah.
a question just came up, Anna, by Lars.
This is Professor Hagander from Uppsala, Sweden. He said, "Thank you, Professor. Well spoken. I wanted to ask you about your position on surgical task shifting for pediatric surgery. Have you any experience of that in your settings?"
Thank you so much. I think that's an excellent question, and that has been one of the initiatives we've been promoting for many years to address basic and essential children's surgical care at district hospital level. Because the reality is our previous work showed that up to 75% of children's surgical conditions can be treated they are not complex, can be treated at district hospital level. And they can be treated by lower level healthcare professionals who have been specifically trained to address those conditions. So for us in Nigeria, in our national surgical plan, we have incorporated that into what we are doing at district hospital level. We are training medical officers. Medical officers are non-specialist physicians who have not had any further training beyond graduating from medical school. So we are training them to provide basic and essential surgical care for children. We haven't done that with non-physicians. The only aspect we are using non-physicians is for anesthesia, and we are training nurses to provide anesthesia at district hospital level. So that's our experience in Nigeria. I know in many parts of Eastern Africa, they also have different types of experience. Thank you.
Yes, when we are talking about task sharing for these procedures, what kind of diagnosis could be treated in the district, you think, within pediatric surgery?
Yeah, so for us in Nigeria, we have categorized the procedures into basic emergency surgical care. So for intestinal obstruction, doing a life-saving colostomy for a newborn with an erectile malformation who cannot get to a tertiary care level quickly, for hernias outside the neonatal period, and for basic trauma care. So those are some of the conditions that we are training them to do.
Yes, and I do agree that anesthesia care can be a challenge there. So what can you do if anesthesia care is not ready available in the district? Are there any conditions you could find a solution?
So for us in Nigeria, because in every district hospital, we have nurses. And what we've done is that we have an anesthesia training program for nurses. So the nurses, most of the district hospitals, anesthesia is provided by nurses who are trained specifically for that purpose. So they are trained by specialist anesthetists to provide anesthesia for these conditions that I've mentioned. And we've tried to create a pathway such that they can easily reach out to their mentors or supervisors. That has not been too successful at this time because of communication problems. But that's what we are trying to do. But our aim, what we've done in the last 1 year as part of our revised surgical plan, is to ask every tertiary hospital to adopt 1 or 2 nearby district hospitals so that they can provide oversight and mentoring to avoid creating a gap for a situation where the providers at the district hospital cannot cope.
I think that's a wonderful suggestion. So you are creating a kind of outreach program for district hospitals so they can lean on a academic hospital. And I do think that like smartphones and photos, they can help as well to show conditions, to make communication easily.
Yeah.
I wanted to thank you, Professor Ameh. It's a very good talk that you gave, because I've been doing some or trying to do some research work both in Rwanda and Bangladesh and Vietnam. And what I find is most challenging, because now, as you say, we are in high-income countries moving a bit from survival or mortality to function, a long times quality follow-ups, follow up to the adult age, and a lot of focus doing that. But there's quite a lot of challenges having this follow-up in low-income countries. It's difficult to reach the patient, get them to come for a follow-up. So that's really a challenge, I think, to have this continuity of care that you are able to follow in the longer period of time. Do you have any thoughts on that, how we are best going to accomplish that?
Yeah, so one of the things we are trying to do, and we are just getting into that, is what we found that almost every family has a mobile phone. And so we are trying to leverage on that to be able to reach out to the patients for follow-up. We are just beginning some work on that. And hopefully in the next 2-3 years, we should have some data and information on that. But outside that, follow-up continue to remain a major challenge. But we are thinking that we should be able to leverage the very wide availability of mobile phones in families to address that.
Thank you, Professor Ameh. There's another question in the chat. I just want to address that. It's from Maria. She says, I'm doing a PhD in global pediatric surgery from an international relations perspective and using the same SDG framework. I agree we need to change narrative in order to redirect funding, but international organizations such as WHO and UNICEF itself don't have pediatric surgery programs. How can we advocate for that, in your opinion? That's the question.
Excellent question. So that was the very first obstacle that the Global Initiative for Children's Surgery faced when we started the initiative. But I think that a lot has changed. We've been able to break into both WHO and UNICEF. They now understand what children's surgery is all about. Yes, no money is coming from them, but they now understand what we are doing. And the Global Initiative for Children's Surgery is beginning to create some programs with them. And as a matter of fact, the Global Initiative has their international meeting coming up in Bogota, in Colombia, in April. And both WHO and UNICEF will be at that meeting. So I think that in terms of that aspect, we are beginning to make an impact. So I think there's a good progress in that regard.
Perfect. And there are two more questions in the chat. One is from one of our global committee members, Professor Balbasnet from Nepal. He's asking, how can low-income country like Nepal maximize pediatric surgical care with limited resources and manpower? That's the question. Any suggestions for Nepal?
Questions. Yes, great
No
questions.
simple questions.
They're not a simple question, but I just want to share my experience. So several years ago, when I completed training, we had less than we had maybe like about 20 pediatric surgeons in the whole of Nigeria to cover the entire population. And one of the things we deliberately decided to do is to deliberately mentor medical students. We tried to make pediatric surgery very interesting whenever we spoke with them, whenever we gave them lectures. And over a few years, we started having large numbers of them coming into pediatric surgery. And we now have a situation where we have more than 130 pediatric surgeons in Nigeria. So I think that mentoring aspect is very helpful in terms of bringing in younger people into the specialty. But in terms of providing coverage, one of the things we also did when we didn't have so many pediatric surgeons is that we tried to provide at our free and spare time, we try to go to other hospitals where the facility existed. Adult surgery is happening there, but pediatric surgery is not happening. So we go to those hospitals for a few days in a month to provide some care. And that was able to help us to gradually take care of some of the children, and also gradually train some of the adult surgeons in those hospitals to be able to provide at least basic and emergency care, surgical care for children. And that really was very helpful for the emergency services. So I think that's the advice I can give for now, but that's really a difficult situation. Thank you.
Thank you, Professor. And we have another question from Professor Hagander in Uppsala. In what ways can high-income country researchers and surgeons be of assistance to college and leadership in low and middle-income countries?
Great question. And that's an area that I've tried to invest a lot of my time in the last several years. I think that in the last 10 years, I think that I must say that the sharing of knowledge and collaboration has significantly improved. I think what we now need to do between our colleagues what we need from our colleagues in high-income countries is that I think whatever research, knowledge, and collaboration that we embark on, I think we need to try to make it as equitable and mutually beneficial as possible, because typically, as we all know, there's some subtle power dynamics that comes in there because the funding is coming from the high income aspect, and invariably the LMIC partners many times don't get to be an integral part of what is happening. I think what we need from our high-income country colleagues is to listen to us, hear what our problems are, and then we work together to address those problems, rather than coming with an idea and wanting that idea to be implemented the way you come with it. I think we need to work together. And I must say that at the Global Initiative for Children's Surgery, that has been working principle and philosophy, and that has significantly helped to gradually move the needle a little bit in the positive direction. Thank you.
Thank you.
Could I ask a question, Professor Ameh? Now, I was looking into your publications, and you recently just in Journal of Pediatric Surgery had a paper on influencing policy to advance pediatric surgery in Africa. You gave us some figures there about the number of pediatric surgeons, pediatric anesthetists. The question is, there is a big gap in pediatric surgery. It's obvious, with the number of children in the country and people trained to be able to take care of them. Does that gap exist with other disciplines as well, let's say general surgery, or does it seem to be more limited to the children age group problem?
There is a systemic workforce gap across board, but the impact is more pronounced with children's surgery. And when I say children's surgery, I mean both pediatric surgery and all the other children's surgical specialties. Actually, in many parts or in many countries in Africa, there are no children's specialists in the other specialties. So, for instance, in Nigeria, for instance, most of pediatric urology is handled by pediatric surgeons because there are no pediatric urologists, no pediatric neurosurgeons, no pediatric plastic surgeons. So a lot of that work have to be done by pediatric surgery. Yeah. So the problem is more pronounced for children.
Thank you.
Thank you. Can I ask you one question also about because you're talking about the policymaker and the infrastructure. I can't help thinking also about the pre-surgical condition. I mean, I think there's a lot of improvements available in low-income countries that doesn't cost so much in trying to prevent trauma, prenatal diagnostic, and so further, to try to maybe you see much further in high-income countries as using helmets on bicycles and beats seatbelt and so on. Do you have any thoughts on that?
Well, in theory, yes, but in practice, all those initiatives somehow are difficult to implement in low and middle income countries. For instance, in terms of trauma prevention, the use of helmets, obeying traffic regulations, they are very poorly implemented. And because of that, we don't get to really feel the impact. In terms of prenatal diagnosis, we still have a problem with that, because even though almost 90-95% of women, when they are pregnant, they get an antenatal ultrasound. But unfortunately, that ultrasound they get is mainly to determine progression of pregnancy and fetal well-being, rather than there's no focus on identifying congenital anomalies. We are just beginning to see how we can train those doing those ultrasounds to be in a position to identify congenital anomalies. Yeah, so even though in theory they are easy to do, but in practice, we still have challenges with them.
Thank you. We have
one last question there. Yes,
maybe last question from Isaac Karagos. Thank you for this inspiring presentation. What kind of project design do you think would be needed to move away from the charity-based approaches and toward a more sustainable model for pediatric surgery?
Great question. One of the working in global surgery in the last several years, one of the things I've realized is that many charity organizations, they have significant leverage with governments and policymakers. When they talk to governments and policymakers, they actually listen, largely because they've been bringing in funding. I think that one of the things we need from those charitable organizations is to, as part of the charity they are doing, is to begin to engage the policymakers to get them to invest, for the government to invest. And I think that one of the things that a few charity organizations do is that they ask the government to bring in what they call counterpart funding. So if they bring in any funding, they ask the government to match it with a similar amount of money. And I think that if they begin to do that at a larger scale, then more funding will be going into surgical care, and they can then gradually begin to pull out and provide more of support, technical support, rather than continuously providing funding support. So I think that that aspect will be helpful.
Thank you.
I think some are trying to raise their hands, but we need to ask them to write the questions there. I don't think we can let them speak on the microphone.
No. Thank you for raising your voice for demand-driven sustainable collaboration in care. Just to wrap up this webinar, I would like to ask you, we as EUPSA, what can we do to contribute to this sustainable collaboration, in your opinion?
Great question. I think that at both individual and organizational level, I know that at individual level, there's already some collaboration going on between EUPSA colleagues and colleagues in LMICs. But I think that at organizational level, EUPSA maybe needs to take the initiative in working with us on some of the aspects that I've discussed in terms of creating, for instance, if we want to create the right stories of children who are faced with surgical conditions, I think that EUPSA probably will be in a better position to help us to do that, as because we may not have the capacity to do those kind of things. So I think those are the kind of collaborations that are low-hanging fruits that I think that we can work on. And as we work on those, other aspects come up, and then we'll begin to move into them. Thank you.
Wonderful. I now give back the word to Gonca and Anna for wrapping up. Thank you.
Thank you, Professor Ameh. We really enjoyed your insights, and we hope that, as you mentioned, we will, as EUPSA, have future collaboration, and hopefully we'll work for the better of the global pediatric surgery. Thank you again.
Thank you.
Same here. Thank you, Professor Ahmed. It was very inspiring. And I just want to remind everyone that the webinar will be on our EUPSA website in 2 weeks. So you can take a look at it there, and also our other webinars. And of course, if you have any suggestion about some theme or presentation you want us to take up in the near future, so don't be afraid to give us suggestion. You can write to me or Gonca or Gaia.
Thank you very much.
Thank you.
Thank you very much
Thank you.
again.
Bye-bye.
Have a
Bye-bye.
nice evening.
Bye.
Good night.
Bye-bye.
Bye.
Bye-bye.